Hi, everyone. I am Rachel Werner. I'm the Executive Director of Penn's Leonard Davis Institute of Health Economics. Welcome to today's seminar, which is Hospice Payment: What's Broken, What Works, and What's Next. So we have a weighty topic to talk about today: the payment and policy governing hospice in the United States. Medicare began covering hospice care in 1983, and that hospice benefit has really shaped how we cover and pay for hospice in this country to this day. Hospice use has grown substantially since then, and today, 1/4 of Medicare spending is for services provided to beneficiaries in their last year of life. At the same time, there are ongoing concerns about hospice care. Concerns that the eligibility and payment system do not support consistent high-quality care. They encourage profits over patients and result in inequitable access to end-of-life care. Medicare's hospice benefit has become a topic of concern for policymakers, and Medicare has begun experimenting with hospice delivery and payment models over the last decade, most recently shifting responsibility for the benefit to managed care plans. The success of these shifts remain unclear, and concerns remain about limited access and inequitable quality. In the coming hour, we will delve into understanding some of the current challenges in the hospice system and potential fixes with some of our country's top experts. I will go ahead and introduce our panelists now. Ira Byock is an emeritus professor of medicine and community and family medicine at Dartmouth's Geisel School of Medicine. He is the past president of the Academy of Hospice and Palliative Care. Mary Ersick is a professor of palliative care at Penn Nursing. She's also a scientist at the Veterans Health Administration, focused on improving end-of-life care. Kimberly Johnson is a professor of medicine at the Duke University and director of Duke's Center for Research to Advance Healthcare Equity, or REACH Equity. There, she focuses on understanding and eliminating racial disparities in palliative and end-of-life care. And finally, David Stevenson is professor of health policy and chair of the Department of Health Policy at the Vanderbilt University School of Medicine, with expertise in quality and safety of care in the end-of-life and long-term care. So thanks, everyone, for joining us. David, I want to start with you. Maybe you could spend a few minutes providing some background to help us level set a little bit. I'd be interested in hearing a little more about what hospice covers, the benefit covers from Medicare, what it was designed to do, and what has changed since it was first developed in 1982.
Sure. Thanks very much for the introduction, Rachel. And I'll try and walk through this pretty quickly. It's a lot of ground to cover, but hopefully it'll level set to get us all on the same field for the conversation to come. So first, the Medicare hospice benefit was instituted in the early 80s to improve the dying experience for terminally ill Medicare beneficiaries. It also had a secondary goal to reduce the intensity and cost of healthcare services at the end of life. The benefit includes a broad array of palliative and supportive services: physician, nursing, aid services, therapy, medication management, bereavement counseling, you name it. It's supposed to be an interdisciplinary approach to providing, high quality services for people with end-of-life care needs. The general mechanics of the hospice benefit have largely been the same since the early 80s, even though many aspects have changed, pretty substantially, as I'll describe in a little bit. The eligibility for the benefit: individuals are supposed to have a prognosis of 6 months or less to live, presuming an illness follows its expected trajectory. That's certified not only by the hospice doctor, but by an individual's regular physician. Hospice also must be elected. It's not a benefit that people are automatically enrolled into because of a prognosis. They must elect hospice. And one reason they need to elect hospice is that hospice is a transition in the philosophy of care. It also requires individuals to agree to forego disease-directed or curative therapies for their terminal condition, as we can talk about a little bit below. This has been a barrier to some people enrolling in hospice. Hospice initially was envisioned for people living at home and primarily with cancer diagnoses. That's changed quite a bit over the course of the benefit. It was expanded in nursing home and assisted living facility residents in the late 1980s. And that's changed a lot over the last several decades in terms of the proportion of enrollees who are in those types of settings in addition to the home setting. Another area, in addition to eligibility, that hasn't really changed a lot is payment. So upon hospice selection, The hospice agency takes over all care related to the terminal condition. That's really important to keep in mind. In some ways, they're at risk for any care related to the terminal condition, and they receive a per diem payment to manage that, whether it's medications, direct care services, durable medical equipment, anything related to the terminal condition, they are responsible for providing underneath that per diem payment. Now, Medicare continues to cover unrelated services, services not related to the terminal condition outside of hospice, whether it's in traditional Medicare or Medicare Advantage. They do that outside of the hospice benefit. Payments are not adjusted for diagnosis. So people with cancer, heart disease, dementia, COPD, et cetera, the hospice agency receives the same payment for individuals with those different diagnoses. It's also not adjusted for settings. So someone at home receives the same payment the hospice agency does as for someone in a nursing home where they might serve many other individuals as well. Obviously, this can create an incentive for longer stays, and we can talk about that. Government has used an aggregate cap to kind of tamp down long stays, and we can talk about other ways in terms of the reforms that have been instituted over the last decade or so to do that as well. So thinking about changes. So after a slow start in the early 80s, the Medicare hospice benefit has really become an integral part of the Medicare program. Around half of all people who die as Medicare beneficiaries use the hospice benefit at some point before they die. But as the program has grown, many challenges and many transformations have occurred. So I'll walk through some of those comparing 2000 numbers from 2000 to numbers now, just to give you a sense of how it's changed just over the last few decades. So there are around 500,000 hospice users in 2000. Now they're about 1.8 million. So it's grown by more than threefold in terms of number. Medicare decedents who use hospice is around 23% in 2000. Now it's about 48%. Total spending going from $3 billion to $23 billion. Users with non-cancer diagnoses fit around 50% in 2000. And just for a point of reference, in 1990, users with non-cancer diagnoses was around 15%. Now it's 76%. So 3 in 4 hospice enrollees have non-cancer diagnoses. The mean length of stay going from 50 days basically to around 90 days. Median length of stay, by the way, has stayed the same. Users in nursing homes have gone from around 1 in 5 to around 1 in 3. For-profit agencies, and this is the big one we can talk about, from around 1/3 of all agencies in 2000 to about 3 in 4. 75% of hospice agencies operate on a for-profit basis. So I know it's a lot of numbers to keep track of. One point I want to leave you with, though, on this piece is that almost all of the hospice growth over the last few decades has been among for-profit agencies, and almost all the growth in hospice use has been among people with non-cancer diagnoses. So it's just something to keep in mind. A final piece revolves around the role of Medicare Advantage. So when hospice was originally created, Medicare Advantage didn't really play a role. Now Medicare Advantage serves around half of all Medicare beneficiaries. And so it's important to keep in mind what happens when individuals who are in Medicare Advantage, which again is around 1 in 2 Medicare beneficiaries, enroll in hospice. Hospice is carved out of Medicare Advantage benefits. So if someone elects hospice as a Medicare Advantage enrollee, the hospice agency takes care of all those terminal condition related services. The Medicare Advantage plan does not have to worry about those. Those come off the books of the Medicare Advantage plan. So again, we can talk about that in terms of reforms below. But so I think that kind of sets the stage a little bit for our future conversation. And we can talk about what has changed in addition on payment if you'd like, Rachel.
Yeah, and that's actually my next question is exactly what has changed in payment. You mentioned some of it, but would love to hear a little bit more.
Yeah, so I mean, the big change that happened in 2016 was, as I mentioned, it's a per diem payment for hospice agencies. That creates an incentive for very long lengths of stay. In fact, around 60% of all program spending is for people with stays of 180 days or more. So it's an issue that the government pays attention to. And in 2016, what they implemented was a staggered payment rate, basically a higher payment rate, per diem payment rate for days 1 through 60, and a lower per diem payment rate from days 61 forward, with a little bit of a bump for services at the very end of someone's life, especially for RN services and social worker services. So that was the first payment change that was implemented in 2016. The other ones that haven't been implemented that have been explored One change relates to concurrent care. And what I mean by that is I spoke about how individuals have to elect hospice and they have to choose to forego curative or disease-directed therapies. Concurrent therapy would allow individuals to receive hospice and palliative care services in addition to services that are related to disease modification. So there was a demonstration between 2016 and 2021 that allowed that to happen on a very small basis. That demonstration is no longer going, and I don't think it's going to be expanded, even though there are some promising findings within it. The second one, which is a little bit bigger and relates to Medicare Advantage, is within the value-based insurance design demonstrations through the Center for Medicare and Medicaid Innovation. There was one focused on hospice, which essentially was looking to, for the carve-in to hospice and Medicare Advantage. And that demonstration is ongoing. It's relatively small again, but it's unclear whether that's going to go forward. I think many think that it will happen, but hopefully the demonstration will inform us a little bit more in terms of how it needs to happen.
So amazing amount of change in hospice in the past few decades. Mary, I want to turn to you next. So some of the financial incentives that David highlighted point to challenges related to quality of care in hospice. And we know that quality of care in hospice is uneven and probably often not as high as we would like it to be. But we also often lack measures of quality within hospice. And so I wondered if you could give us a little bit of a lay of the land related to what we know about quality of care in hospice and some of the barriers we face to providing high quality care.
Great, thank you. Actually, we do have a program, a fairly robust program for monitoring quality, at least publicly reported measures. And it's called the Hospice Quality Reporting Program. Now, it's a little more recent than the quality reporting programs that we've seen in hospitals and nursing homes. And initially, it was rolled out as part of the Affordable Care Act and was first implemented in July of 2014. At least certain elements of it were. There's four major components to this program. The first is the hospice item set, which is a standardized data collection instrument that the hospices themselves collect, and it measures the proportion of patients who receive, 7 care practices, care processes that are deemed best practices by hospice experts. They're very limited. Hospices have to collect these themselves, and they are process measures. So they're things like the percentage of hospice patients who, by chart documentation, have discussed with a hospice staff member preferences for life-sustaining treatments, or the number of the percentage of patients who who are screened for pain and have appropriate follow-up. The next couple measures use Medicare claims data, and the advantage here is that it's less of a burden for the hospice agencies. It's also probably less opportunity to game the system and report things that don't quite reflect actual care. The first one, and this I think follows up on David's comment about this difference in payment that took place fairly recently, is one of the measures is hospice visits in the last days of life. So this is the percentage of patients who received visits from a registered nurse or a medical social worker in the last 2 of 3 final days of life. And that reflects that what we know clinically is that the needs of patients and families increase in those final days. The other Medicare claims outcome measure is the Hospice Care Index, and this was just implemented in 2022. And these are 10 indicators of care derived from, as I said, Medicare claims, things that we know are associated with better care or worse care. So are there gaps in skilled nursing visits? Are there 2 weeks that go by when there really, someone should have received 2 nurse visits? How many live discharges, which is a huge issue in hospice that we might talk about later. or the number of hospitalizations. In theory, one of the ways hospice saves money is to decrease the number of hospitalizations. Moreover, people choose hospice because they don't want to be hospitalized anymore. So the number of hospitalizations. The fourth measure is an after-death family caregiver survey, and it's called the Consumer Assessment of Healthcare Providers and Systems Hospice. So CAPS is how we refer to that. This is a very similar family or consumer survey as used in hospitals, not in nursing homes, but hospitals and other healthcare settings. This was required beginning in 2015. And what this survey does is it's mailed out to bereaved family members, and they report back on various aspects of end-of-life care that we know are important to families and patients, plus 2 overall items measuring the quality of overall care. So overall, the bottom line is these hospice quality measures exist. They cover the gamut of processes and outcomes. They include data from multiple sources. This is all standard and very similar to what we see in nursing homes and hospitals. However, there's a couple of caveats, I think, for measuring quality in hospice. One is hospice is focused on home care. And that means most of the care is provided by family caregivers when the patient is in their home. And as David points out, the growth of hospice patients whose primary residence is in a nursing or an assisted living facility has grown exponentially. And hospice agencies can't always control the quality of care that occurs because most of the care is going to be, end-of-life care is going to be delivered by staff in these facilities. And so I think one thing that's a challenge is teasing out the relative contributions between the care that hospice gives and the quality of that care versus the care of end-of-life care that a nursing home or assisted living staff provide. And we don't really have a good way to tease these out. And I think that's a major issue. Second, many hospice agencies are exempt from reporting, often because they're too small or they're too new. And remember the growth of hospice. There were 300 new hospices that came on board between 20 and 21. Not a huge number in that 5,800 number, but still growing a lot. And so to gauge I don't know how common it is that these outcomes are not reported. So what I did is I logged on to Care Compare using my dad's zip code. My father died under hospice care. It was an amazingly positive experience. But I logged on and just like what would be available to my dad. There were 38 hospice agencies that came up for my dad's zip code in a suburb of Cleveland, Ohio. An astonishing number by my estimate. And of those 38, 18 had missing quality data. Now, I know that these represent a small number of patients because they're small. That's why they're not reporting. Nonetheless, 18 hospice agencies, that's a lot. And I think it's a huge gap in our understanding of the quality of hospice care writ large, as well as the quality of care that specific agency delivers. Finally, and most importantly, we need to leverage the quality data. It doesn't matter that we collect it and report it if we're not going to do anything with it. And I think this is where some of our major opportunities are. We can use these data either to provide carrots, that is to support hospices to review their data, to engage in quality improvement activities. We can use them for value-based purchasing programs to reward the delivery of good care. And we can also use sticks. And I'm afraid that there's probably a need to apply some sticks here. And that's in the form of monetary penalties or increased oversight. And I think in response to several exposés, including a major expose in the New Yorker late in 2021, I'm sure we all remember that, Ira, it was a painful reminder of something that I think we were all aware of. But anyway, this expose uncovered a lot of fraudulent hospice practices. And in response, CMS called for several changes. And in January of 2023, they established a hospice special focus program. So that's similar to what we see in nursing homes, which increases oversight and potential penalties for the lowest performing hospices, enhancing educational requirements for hospice leadership and management, revoking billing privileges. In addition, CMS called for enhancing and standardizing the state survey process. So this is a process similar to what we see in nursing homes, also done in hospices. And it includes conducting more unannounced surveys, more on-site visits to hospice agencies. And I hope that those survey results, like they are in nursing homes, will at some point be reported on Care Compare and other public reporting. And I also hope that that Care Compare clearly indicates these special focus hospice agencies as we do with nursing homes. So I think all these efforts are needed to continue and expand and ensure that all hospice patients receive the highest quality hospice care.
Okay. Thanks, Mary. So Kimberly, I wanted to turn to you next. Mary has laid out some of the challenges related to quality in hospice care. And like many areas of care within healthcare, quality concerns are disproportionately borne by Black and Brown Americans. I wanted to ask you how the current hospice system might further disadvantage those who are already disadvantaged in the healthcare system, and hear a little bit from you about how racial disparities in care show up in the hospice system today.
Great, Rachel, happy to talk about that. I mean, I think that there are a couple of ways we can think about disadvantage, and we often do when we think about equity and disparities, those around access and then those around quality for people who actually have access. There are tons of data documenting lower rates of hospice use for individuals from minoritized racial and ethnic groups. We know that, as David has described, there's been this enormous growth in hospice, yet these gaps in use based on race and ethnicity still persist. In the last reporting by NHPCO and their facts and figures, for example, you look at this tremendous use of hospice among Medicare beneficiaries. If you examine this by race, about 50% of Medicare beneficiaries who died in 2021 used hospice services. If you look at that number among Black and Hispanics, only about a third of those who died during that same year used hospice services. So you see this huge gap. Another way that we look at that is relative to representation in the general population. We know that compared to their representation in the general population, particularly as we've seen this grow in diversity, that white individuals are actually overrepresented among hospice participants as compared to Black or Hispanic individuals. For instance, Black individuals make up about 8% of all hospice enrollees, but they represent about 12% of the US population. And when you think about the fact that diagnoses that are more common among hospice enrollees, like cancer and heart disease and now Alzheimer's disease, are more common for these minoritized racial and ethnic groups, these disparities are actually even larger than they appear. I think if you think about kind of how these things show up and what might be at their root, particularly from the payment and policy perspective, David did a great job summarizing what it takes to enroll in Medicare. It's a benefit that you elect, and you elect supportive and palliative treatment of your terminal illness in lieu of life-extending services. We know that as a group, for instance, Black Americans are more likely to want life-prolonging therapies even when prognosis is poor, right? And so if those are your preferences, hospice as it's currently structured, and I always talk about hospice as David described it, not just being a set of services, but a philosophy of care, really may not be consistent with your values and goals. And so that really creates issues of access. I think thinking about concurrent care models is the way really to expand that, really, rather than having people to choose either or, how we really think about care and serious illness as a continuum, right? People are often still desiring to receive some life-extending therapies, but both the philosophy of care and the payment as it's currently structured doesn't allow for that. So if people are still wanting to receive blood transfusions, which may be life extending in the face of their terminal illness or even dialysis. Those things are not generally part of the hospice package, and as it's currently reimbursed, would not be tenable for most hospice agencies to actually provide those kinds of services. I think that also shows up not just in lower rates of enrollment, but higher rates of disenrollment for people who are members of minoritized racial and ethnic groups. In our own work, we've seen that Black patients, for instance, are more likely, and there are tons of other studies, to disenroll from hospice to seek life-extending therapies or to seek acute care services. So really thinking about how do we create a model that addresses this broad and diverse group of preferences that exist in our society and others. I think another potential disadvantage to access for members of minoritized racial and ethnic groups have to do with the social drivers of health. As Mary mentioned, lots of the vast majority of hospice care is practiced in the home in its initial benefit structure. That was the goal, particularly for cancer patients and now for other groups. But if you already face, substantial structural disadvantage, then thinking about how to care for your loved one at the end of life in the home where you may not be available, where you may have lower socioeconomic resources and be required to work, really just becomes not possible. As a provider, I often see people who are really interested in going home, potentially with hospice care, but can't imagine how they would take care of their loved one at home. And so in our work, we've also found, just in terms of looking at what hospices sometimes do to the extent that they can, but probably can't do enough, is really providing the other kinds of things that people need when they're at home at the end of their life, food, housing, transportation, and other kinds of resources that really facilitate people being at home and comfortable, besides opioid therapy and nursing care. And so I think that those are disadvantages which are that disproportionately affect members of minoritized racial and ethnic groups or other disadvantaged groups. And, finally, if you think about issues around quality, Mary has talked about that. I think we can talk about how we really need to do a better job of measuring quality, particularly as it relates to equity and disparities. Somehow we've developed these systems of quality measurement that don't actually look at or stratify by disadvantage. And so we don't know which groups might be disproportionately affected by lower quality hospices. What we do know from some of the data is that African Americans in particular are more likely to be in hospices that have greater issues with care coordination, for example, or providing services and visits from professionals in the last weeks or days of life. We also know that in some of these data, some of the surveys that Mary mentioned, that you see that caregivers of African American patients are less likely to report high quality care. And so we know that those issues of quality, the same issues that we see throughout the healthcare continuum, do exist at the end of life, even for hospice providers. And it's been great to see this kind of recent push to think about measuring equity and measuring disparities across healthcare systems, including in hospice and home health. And CMS has actually recently developed some frameworks around that.
Okay, thanks. That's super helpful. And I'd love to sort of return to some of those topics. But Ira wants to jump in.
Well, I loved, Kimberly, what you just had to say about disadvantaged populations by demographics. I would just want to add to that people who live in a rural area have a far more difficult time accessing hospice care, particularly high quality hospice care. There are regional variations. Medicare data shows that in Utah has the highest rate of hospice use, over 60%, while New York State has less than 25% of Medicare enrollees who die receiving hospice care. So you don't even, in that environment, you don't even know that you're being disadvantaged, but the way things are done there actually contributes to having less access, for instance, in New York State of all places. And also there are age differences. In the 85 or older age group, there's almost a 60% chance of having hospice care before one dies. Whereas if you're less than 65 years of age, you have about a 26% chance of receiving hospice care. So there's lots of variations that we all, as we try to improve both access to hospice care and quality of care, we need to continue to keep in mind.
Completely agreed. Thanks for that, Ira. Definitely all of those, including the variation by socioeconomic status. So really thinking about all of those groups that make up populations that experience health disparities. Definitely important. I grew up in rural Mississippi, and actually my mom worked as a hospice nurse for a very small agency. Now there are multiple agencies in a very small town, but certainly there are huge issues even when people can access related to quality and variation in quality.
Okay, thanks. Ira, I want to ask you sort of a question and have a step back a little bit. First, I want to note that Ira has provided some additional reading on hospice reform. We will put a link to that reading in the chat. It's a couple pieces he has written, which can help provide some context to hospice care. Ira, I wanted to ask you, as I said, to zoom out a little bit. We started out hearing from David, who provided a high-level overview of the structure and the evolution of hospice care. But I want to hear from you about your view of hospice, given your experience as a clinician, and wondered if you could talk a little about how hospice has evolved in your eyes and what hospice does today compared to what it was meant to do.
Thanks for that. I'm so delighted to be part of this panel. So back in the day, and I've been involved in hospice care since literally 1978, 79, while I was in my training. Hospice was more of a social movement. It was more of that philosophy rather than delivery models of care. Hospice really was engendered by nurses, frankly, who watched people die badly, often in hospitals, often in pain, too often alone, and said, we have to do something better. So with nursing really driving the evolution of hospice care, and a few of us renegade young doctors joining on, we decided to develop a delivery model that tried to give patients some continuity of care so that they could continue to see doctors who at the time, back in the late 70s, early 80s, didn't feel like they had a role in caring for people through the end of life. Once people were deemed to be dying, it honestly, within the culture of physicians, it seemed like we were no longer needed. Why do they need us? This is nursing work, and frankly, women's work, was about only about social issues and hygiene and that. Trying to get people home. Home-based care was really a major emphasis. As has been laid out by David and Mary particularly, hospice has evolved because of the delivery model that became embedded within Medicare. There became a financial support for hospices to grow, and also an advantage to some extent for the larger healthcare system to make use of hospice, keeping people out of the hospital, making sure their needs were met. As it has evolved, it went from being an almost totally nonprofit, at the beginning, a volunteer model program, to gradually becoming a more professional model with hired interdisciplinary teams of doctors, nurses, social workers, chaplains, as it evolved now, and nurse practitioners to meet people's needs. The challenge to hospice through most of my career has been that terrible choice, being able to having to present people with the option of continuing to get cancer care, which was the dominant diagnostic group receiving hospice care for the first few decades of hospice's existence. You can continue to get cancer care through your oncologist and the cancer center, or if you're ready to give up, you can get this wonderful model of care for your comfort and your family support through this thing called hospice care. And although hospice was a brilliant model, really one of the major advances in American medicine that I've been privileged to see over my career, having to accept that you were dying was an incredible barrier, and one that still persists today, and is a challenge in the new payment models going forward. Death remains a hard sell, right? As it has grown, we've seen it be utilized more by patients with non-cancer diagnoses, heart failure, Alzheimer's, and other dementias and the like. But that terrible choice continues to be a problem. We've also seen, as has been discussed, the real blossoming, if you will, of the for-profit programs. And just for context, I am not against for-profit hospice care. I mean, I'm an American, I'm a capitalist. I think that there is a place for for-profit hospice care, but for-profit programs must succeed by delivering consistently high quality care. And unfortunately, that's not what we've seen. When the for-profits began in the late 1990s or mid to late 1990s, I was actually a champion for them because I thought it was a highly efficient way of being able to develop high quality, high functioning, efficient hospice programs and delivering a reasonable return on investment. But those initial for-profit programs were wholly owned by individuals or families that were zealots for access to services and quality of care. And what I saw repeatedly over the early 2000s was that some of the very best for-profit programs went through IPOs, initial public offerings, and became publicly traded. And then, despite the protestations of the founders, who usually stayed on for a couple of years during this transition, we watched the quality spiral down, and the attitudes of the management of the new publicly traded programs focus on finances, frankly. So now scroll forward, and you have what we're seeing as what I fear is a death knell and really possibly a terminal degradation of hospice in America, where there are still plenty of excellent programs. Most, though not all of them, are nonprofit hospice programs. But we're also seeing huge variation of quality. And that tracks to some extent because through profit, because a high quality, well-managed nonprofit program will yield somewhere around 5 to 6% profit margin per annum. But the for-profits, particularly the publicly traded or private equity for-profits, are yielding in the range of 18 to 20 to 22% annual profits. They do that in large measure by skimping on services, tolerating unmet need among the dying patients and families they serve, shifting costs to families, short staffing in nurses, making hospice nurses maintain very high census on their own caseloads, and short staffing of doctors, so that ironically, I'm seeing doctors go away from hospice care. I mean, it's such cruel irony to know that at the beginning we created hospice in part to ensure dying patients access to physicians, and now in a number of programs, the hospice programs themselves are the barrier to dying patients seeing doctors. Doctors are hired to simply certify or recertify. They hardly attend interdisciplinary team or attend it for a few minutes. They basically have the sit down, shut up, and sign management of doctors and nursing in hospices these days. And we're seeing poor responses to emergencies. So lots of different changes. Let me just say that even without these profit changes, there would be challenges to the hospice model as it was initially developed, because late-stage treatments for disease, including cancer care and heart failure, have gotten so darn good that it really is hard as a clinician to know when people should make that either or choice. And what we're hoping for is this smoother continuum of care, which we'll talk about the carve-in I hope more, but which the carve-in has the bright potential of offering.
So I'm going to take that opportunity to thank you, Ira, to talk about the carve-in. The carve-in has come up a few times. Maybe, David, I could turn back to you and first remind us what the carve-in is. And then I'd love to hear from all of you. Is this like the final nail in the coffin for hospice, or is this the best thing that's happened to hospice?
Sure. As I mentioned earlier, I mean, hospice has been carved out of Medicare Advantage benefits, throughout. And so what that means is that if a Medicare Advantage enrollee elects hospice, the hospice agency and not the MA plan is responsible for anything related to the terminal condition, all those services. The only thing that remains the responsibility of the MA plan, any services related to non-terminal condition needs, and also any supplemental benefits that they provide. And so what that's done is, it's kind of given MA plans a little bit of an out in terms of not having to remain responsible for individuals with serious illness needs who elect hospice. They can instead encourage them to enroll in hospice, and then they don't have to, remain responsible for providing those services. So what the carve-in does is, obviously kind of the opposite. It, would keep hospice services, within the MA, plan benefit, presumably paying them more, since they'll be providing additional services. And, what we've talked about a little bit is, potential conceptual advantage of that is that an individual wouldn't have to make a choice somewhere along the way, to say, okay, I'm now transitioning from my regular MA plan enrollment to be a hospice recipient. The MA plan could just manage their serious illness needs along the way. As needs arise, as opposed to paying attention to prognosis, paying attention to foregoing curative therapies, depending on how the regs were written. That would be ideally how it could go. And I think in theory, MedPAC, first kind of, pushed that as, the way to go in 2014, I think, and I and others have written about it. Conceptually, I think it's a really good idea because, that's what MA plans should do. They should manage people's care from when they enroll as Medicare beneficiaries when they're relatively healthy, all the way through to the end of their lives. That's ideally what, I would love to see in others, but there are challenges to it. As Mary said, there aren't great quality measures in hospice. A lot of the measures she mentioned, either A, they're not there for hospice agencies, or B, they don't distinguish across hospice agencies. And so if MA plans were engaging hospice agencies and other staff to provide those specialized services, we wouldn't necessarily know the quality of it. The other thing is, in terms of, MA plans and their own behavior. We mentioned the for-profit, aspect of hospice care and how 3/4 of hospice agencies are now for-profit. MA plans have also had some problematic behavior in the market. I think we'd have to navigate that and be confident that we wouldn't, have unintended consequences in terms of people enrolling in hospice or getting those services while they're in the MA plans. I mean, if you look at United's purchase of Amedisys, United's purchase of LHC Group, Humana's foray into Kindred at Home services, MA plans have a financial model in mind as they're thinking about these services. And I think Medicare program and policy planners need to keep that in mind if they're going to keep going in this direction.
Anyone else want? Thanks, David. Anyone else want?
Oh, sure. That was a lovely, accurate, and understated sense of the dangers. I think, Mary laid out some of the efforts that Medicare has taken to improve quality measures and reporting, and they are earnest and they're good. But it hasn't worked to this point. And Medicare has tolerated many hospice programs continue to have licenses and certification to bill Medicare while they aren't fulfilling their conditions of participation. Over 50% of American hospice programs do not provide any general inpatient level of care, like a hospital level of hospice care or continuous home care. Those are the two intensive levels of hospice care when patients are really suffering and in need of an intensive higher level of hospice care. Those quality measures, if you think about the Donabitian way of measuring quality of structure, process, and outcome, there are even structural elements such as how many physicians are on staff per numbers of patients, patients per position, or the other way around, what the nursing caseloads are that aren't reported to the public. So those are things that I would use to make choices. How often interdisciplinary team meetings are held, and whether the physician actively participates. Those are information that I would want to have if I was being able to choose. So we have a situation where, as the carve-in is likely to happen, we have an information gap about important structural and process metrics that could be measured and reported that aren't. And so without those metrics, I worry a lot that the United Healthcares or the Humanas can simply allege that we provide excellent hospice care, and how would we refute those those assertions? We don't have the tools. And so, I've said before, let the dire beware. It's really worrisome whether patients in MA programs will have fair access to high quality programs. Although I'll just end by saying I agree with David that theoretically and abstract, this should be a very good thing to reform hospice care and offer a continuum of high quality care to dying patients and their families.
Thanks. Kimberly, I want to maybe ask you specifically about this. One of the concerns you brought up related to equity in hospice was that the need to transition from receiving medical treatment to just receiving palliative treatment has been a barrier for many people. And the carve-in, to some degree, might address some of those barriers. And I wonder what your view of this and how it might affect those concerns are.
I mean, I was really excited about it until Iris started talking. So now it's like, this is a bad thing and I missed it. Perhaps I'm more optimistic. I guess I was really excited for a couple of reasons. I think continuity is always good. It's also something that's often missing from disadvantaged populations, whether it's about race, ethnicity, SES, or rurality, as Ira said. And we know that, when people have that kind of continuity, that overall quality and access are improved. And so as I saw that, I got excited because there have been a number of models at the level of some insurers or other agencies where, in fact, they've tried to create this level of continuity where people who have serious illness start getting enhanced home care services, which I think are largely what we might call palliative care, right? They continue to receive disease-directed therapy, but they're also getting good pain management and care coordination and support for their families. And we've seen in a number of those programs where you see subsequent use of hospice and access for minority populations in particular actually increase. So that really suggests that this continuity and more kind of gradual progression of how I think my patients kind of view their life course and movement to the end of life go actually does seem to promote equity. So I've been really excited about that, but it sounds like Ira is telling me in principle, yes. In practice, I better let the dire beware. And so I think that it certainly makes sense from that perspective, that if people are really allowed to have choice and transition, but really benefit from enhanced services as they go through, that you would see that kind of reduction in equity. We've seen that in inpatient settings where there's high quality palliative care consultation. We see fewer disparities in subsequent hospice use among groups for which there are generally lower rates. So I guess I'll remain cautiously optimistic.
And Kimberly, just to add to that, I think, for MA plans, it could make, if hospice is carved in, it could make the choice unnecessary depending on how things are structured. But MA plans still have, or people with MA plans still have the challenge of serious illness care, which, has not always been that great, among MA plans. And there's been higher levels of disenrollment for people with serious illness needs. And I think that's still going to be a concern no matter how this is structured. Just access to that specialized treatment is not necessarily going to be any easier, even if there's a carve-in.
We have about 10 minutes left. I want to focus for a minute on financial incentives before we move on to your most optimistic views of hospice. So we've touched on the financial incentives of hospice, and the carve-in may be one way to address it. We've heard some pros and cons about that. But I think it's also been clear that the current financial incentives have created some problems within hospice with the rapid growth of for-profit agencies and increased use in nursing homes and the like. I wondered if we could talk just for a minute about whether there are alternative approaches to addressing these the financial misalignment that we see in hospice that you think are promising or working, or how you would approach addressing some of these financial incentives that are currently causing some of the challenges in hospice. So how do we change the payment?
Yeah, I'll jump in, with something here. I mean, in addition to the carve-in, I mean, the biggest elephant in the room is, the per diem payments that exist, because it makes it relatively easy, as Ira mentioned, for agencies to have high profit margins if they really largely serve people with longer lengths of stay. That's a big element of it. So reforming that further, is probably, the most obvious place to look. And you can take a variety of approaches. You could also think about, nursing home, hospice use, where the nursing home, if it's a dual eligible person, they're still getting the nursing home payment from Medicaid. And, the hospice agency is getting the hospice payment, despite the overlap in services between what the nursing home is supposed to be doing for people at the end of life anyway, whether they enroll in hospice or not, and then what the hospice agency is getting. And by the way, the hospice agency gets both of those payments, and then they pay the nursing home back. So there are also other opportunities for, I won't call it collusion, but, basically, kind of negotiation, around those payments. And I certainly think, and have written, with others before, that type of payment could be reformed, because bringing additional resources in for end-of-life care in nursing homes is a great thing. Hospice has done that, but I don't think it's the most efficient way to do it.
Yeah, and I think the more that we tie payment to quality, which doesn't seem to be happening much in hospice, I think we absolutely have to do that. We have to demand more. Just look at the hospice expenditures that David talked about from a decade ago to now. I think we've got to tie it to quality. And there are models for that.
You think we have good enough measures of quality to be able to do that?
Yeah, absolutely.
Well,
Shaking.
I think there is data available.
I think we do need to move.
I think there's data available, or that could be readily made available, that aren't currently within quality metrics.
Right. Just all those missing data.
Well, and the HOPE assessment
surveys.
tool, I think, holds promise as well. It's, an MDS-like assessment instrument. I think that will allow us to do some things that we haven't been able to do yet in the hospice space.
There is just other data, as I mentioned, caseloads of nurses. There should be some variation depending on geography and windshield time and all that, but not that much. A hospice nurse who regularly has 15 to 18 patients on his or her service is unable to provide high quality care. That person is going to burn out, charting at 11 or 12 o'clock at night and the like. It's just untenable. A hospice program that has one physician for 75 or 100 dying patients that's not face validity. It just doesn't. There's no way that program is going to deliver high quality care. I would just add another thing that we ought to be looking at, I think, in quality metrics for hospice programs is annual turnover rate among nurses and nurses' aides. That's a less gameable metric. And frankly, when I look at nursing homes over the years, that's the metric I want to see most. If I was to choose a nursing home for a patient or a family member, I want to know if the annualized turnover rate is 80 or 90%, there's a problem. If it's under 25%, something right is going on in that nursing home. And I want to know about that as well.
I'd also want to know a little bit more about differential delivery of care and outcomes in various settings. Some hospice agencies have 80% of their patients are in assisted living or nursing homes. That makes me suspicious, but on the other hand, perhaps that's a hospice that's highly dedicated, knows that setting well. I think there are different expectations of families when they're caring for a loved one at home versus in other settings, how much you're using general inpatient care or using a hospice house. I do think, in response to what Kimberly was saying, it's the opportunity to go inpatient to an inpatient hospice facility, not GIP, is very limited. And I think that disadvantages people who have limited family resources. And so what kind of opportunities do we have there to improve care and look at metrics that look different? I mean, the same metrics, but how do we look at those differently according to the setting?
Okay, I'm going to ask you guys each one final question, and that is that the title of the seminar promised we would cover what works, and we've heard a few glimmers over the course of this conversation of some optimism, but I wondered if we could go around the virtual room and hear from each of you about what one positive trend or development is that makes you optimistic about our ability to improve hospice care. Ira, maybe I'll start with you, and we only have 3 minutes, so have to be brief.
Well, I think hospice, even as it was initially designed, works beautifully. It is a brilliant model of human caring. And so we shouldn't give up on some of these reforms and metrics to really highlight what goes well. I do think the PACE model is really one that deserves continued attention, and that hospice skills, knowledge, attitudes, and skills could be integrated more deeply within the PACE program to expand access and quality. And then there's, PACE, without needing to be duly eligible. So I think those models give me some hope that, we could get this done.
Okay, thanks. Kimberly, do you want to go next?
I don't know. I'm afraid to be too optimistic with our room.
We could use
I
some
feel so
optimistic.
badly, Kimberly.
I know. I guess a couple of things I would say. One is, while I really highlighted some of the gaps and disparities in hospice use, the fact is that there's been really the substantial increase in use of hospice services among all groups, even though there still are differences between advantaged and disadvantaged groups. And so that does suggest increased access, even with all the issues that we've identified. And then I think the second thing that gives me some hope, I don't think we've gotten this right, and I was really disappointed after I saw that the Medicare Choices model was not going to continue, even though the outcomes were good. I was excited to see, one, that in fact was a demonstration project and may in fact reflect at some level a recognition of a need for changing models that really that are more inclusive and really more fully address the needs of diverse populations.
Great, thank you. David?
Yeah, no, I appreciate everyone's perspectives on this. Hospice has improved end-of-life care for millions of people over, the course of its history. Its chassis is pretty outdated at this point. I think things to mention, a few separate elements that have been good developments is, getting, better quality information. I think, we've struggled a little bit with CAPS, hospice item set, hospice care index. I think the HOPE assessment tool will be another tool in that toolbox that will be useful. I also think greater transparency in the sector in terms of ownership and the provision of care services. Learned a little bit from the nursing home sector, how important that is. I think that will help, in addition to a little bit, more scrutiny in terms of the oversight that happens. And then finally, I think, palliative care models have developed, in terms of outpatient palliative care models that hopefully can be integrated a bit better with hospice as these payment reforms go forward and you think more about value across the continuum of serious illness. I think we've learned a lot about how to do that better.
Great. And Mary, you get the final word.
I would say integrating hospice more into healthcare, whether it's with carvins or whether it's with palliative care. I would offer my own example within the VA. I think we've integrated all aspects of end-of-life care fairly seamlessly in ways that do not require terrible choices or decisions about where one lives or where one receives care. And I think just to remind people, despite all the problems, about 81% of people who are asked, please rate the quality of care that your loved one received in hospice. And I think consumers have gotten a lot savvier about hospice since the 35 years ago when I started. I think these are pretty savvy people, and 81% of people rate care as excellent. So we're not doing everything wrong. We just have to make sure that we keep that at that high and push it even higher.
All right. Well, thank you all. I appreciate you all spending a little bit of time with us today to talk about this important issue. And thanks to the audience for joining us as well. We will be back here on April 19th for our next virtual seminar, which is about rural hospitals. Similar questions, different setting. Rural hospitals at a crossroad, access, quality, and financing. So we hope to see you then. And until then, take care. And again, thanks to our panelists.